Thank you so much. Well, you probably want to dim the light a little bit, then you can see the slides better. You don't have to see me, actually. So. Well, thanks for having me. Thanks for having LoKomat. I really enjoyed the talk so far. It was very interesting, and it's great as well to be able to respond to certain questions. Probably came up on upper extremity, but much more on lower extremity, because I really want to talk a little bit more about the LoKomat, what happened over the last few years, and as well, in terms of evolution of the LoKomat, and in terms of research that is now available, which probably is a little bit different than we heard just in the talk before. So LoKomat, as Mindy mentioned, is Swiss-based. Switzerland is known for watches, Swiss chocolate, and the Swiss Army knife. Right? So I'm not going to talk about kind of the precision of a Swiss watch and the high quality of probably a LoKomat. I'm not going to talk about how the patients or physicians like the LoKomat. I really want to talk more about the functionality of this device, and again, what happened over the last few years, and what kind of algorithms we try to incorporate to change probably what we learned as well, and to make the device more efficient, more beneficial. LoKomat is important to know. Switzerland is very small, so if we tried to do this all in Switzerland, we would never succeed and probably would never be able to come up with good technology and beneficial devices. So LoKomat collaborates very internationally with leading rehab centers and universities. And I think you see on the left side, and this is just a kind of a selection of centers, and on the right side, kind of the devices where we collaborate with them. And we mentioned, or we heard already, about upper extremity. And I don't want to go into details here, but I think it's important to understand LoKomat has not only the LoKomat, we have upper extremity. We started actually with the so-called Armeo spring here. That's from David Rinkensmeyer, a name you heard this morning. He kind of developed the prototype, and LoKomat commercialized this device, which is a non-robotic device, a device that encourages a patient to self-initiate movement with very successful results so far. And then, as we heard this morning about the Armeo Boom, probably more kind of an outpatient home device eventually. And we just introduced the Armeo Power, which is kind of a robotic exoskeleton. And again, important for us, when we talk about upper extremity, LoKomat has products which really try to embrace the full arm from proximal to distal components, knowing that we want to have exoskeletons and not focusing on end-effector-based devices. We're probably going to hear more about that later on, or probably heard about the rechoice already. I talk about here, and this is my last thing on upper extremity, hand function is very important, and we certainly want to incorporate hand function as well, because what we have right now is limited here in terms of hand functionality. And obviously then the future here, home version with sensor-based technology, might be as well something where we probably see that a bit more in this arena as well. Now about the LoKomat, this is kind of the latest version. We always try to follow a certain continuum of care, so we understand patients, they progress over time, and certain patients, or during this rehab phase, they need certain approaches or various technologies. And in a very early phase, we have a so-called Erigo, a tilt table, in the future with FES integrated as well, to really bring these patients to a certain level where they can become functional and really do some activity-based treatment like the LoKomat. And when we now talk about the LoKomat, this is the device 1998, kind of the first prototype. And when we asked therapists, do you want to use this device? Do you want to put your patients on such a device? They always say, well, no way, that's not safe. And anyways, we are used to use our hands, so a robot is probably not going to do it. And obviously, we tried to then incorporate all their feedback and develop the LoKomat further. What we probably heard about the first device, the first version, and I don't agree that it's a failure, because it certainly helped us to learn quite a bit and to further develop the LoKomat. But what we did here, we incorporated biofeedback to provide feedback to a patient, that not only the patient knows what he or she is doing, but as well the therapist sees how active a patient is while walking on the device. What we heard this morning already, it's a body weight supported device. These legs are actuated and the patient is walking over a treadmill. We as well included assessment tools to measure probably more objectively what and how well a patient is walking and is doing in terms of what kind of activity is produced. We can measure range of motion and as well as certain mechanical stiffness for the hip and the knee joint. Again, this was 2004, and now 2 years ago we further developed, again, brought kind of a new version of the LoKomat to the market. And this now, I think, is answering a lot of questions that really kind of didn't probably produce the results we initially thought a LoKomat will help and will do. And the main features we introduced is a so-called augmented performance feedback, where we again want to augment the feedback to a patient, how well she or he is doing. We want to provide a feedback about how, again, the result that is produced, and as well what kind of performance a patient is producing. At the same time, and this is probably very important as well, most of you can see this term down there, it's called cooperative control strategies, so that we want to work on the LoKomat and make the LoKomat more intelligent and offer a so-called assisted needed approach, so that the robot would only support when it's needed, and when a patient can do it on his or her own, the robot wouldn't really support at all. Again, when we now look at this kind of innovation curve where we are with the LoKomat, then I think here really the very innovators, RIC, for instance, was one of the first centers in the US adopting this technology and working with us to further improve it. We then kind of had the early adopters. And I think right now we see the device in a phase here. The LoKomat will continue to develop. We will add new features in terms of additional degrees of freedom, in terms of probably then again more sensing mechanisms or additional feedback modalities. But this is where we see the LoKomat right now. And because we heard about the pediatric version as well, just to introduce shortly what this is, it's kind of the same principle, it's just a smaller version of the LoKomat. An example how this looks like is here. So the patient again is in the device, and what we want to do, and we see now how he is focusing up here, we want to have this activity-based approach. So we need to provide feedback that the patient is not slacking, but is as active as possible throughout the whole training phase, as long as the patient can be as active as possible. This is an example of a CP patient, just to give you kind of a clinical picture how the LoKomat can be used or is used. So this is a patient before surgery. Then this patient did go through surgery, and after this this procedure, they had this child on a LoKomat for about 20 sessions and could get these results. Very important, and whenever we show kind of pre, during, post videos, it has to be mentioned the LoKomat alone is certainly not producing these results. The LoKomat, how we see it, is an adjunct to an existing clinical setting and is not replacing treatment modalities as they are known. It's just an additional component with probably more intense training, with probably better feedback to a patient to really augment motor learning and treatment outcomes. So what we always try to do to kind of figure out, well, what is really needed out there. I mean, it's nice to have a fancy robot, but at the end it really matters, is this device helpful, is it meaningful, and is it producing outcomes and better rehab results. So this kind of, what is the market really asking for? And obviously the market is our rehab centers, our physical therapists, our occupational therapists. So when we asked them about 10 years ago, and this is again, when we really started with the LoKomat, the answer was, well, we would like to have a device that allows mass practice. So really this intensity, that's an important component for us. We would like to have a device that can help me to probably move my patients, to offer a functional task-specific training, but I would like to get a little more support. I would like to have a device that offers active assistance. I would like to have feedback that motivates a patient, and I would like, obviously as well, to measure and record what we are doing so that I can change my training modalities over time. And I think we did a fairly good job to incorporate all these needs in the LoKomat. Now, over the years, these needs obviously changed a little bit based on new evidence-based data, and what we now know, and again, you probably can't read that because it's down here, now the needs are additional to the above ones. It should be challenging, again, intensive, and it should be meaningful practice. And at the same time, a robot is probably not enough if we just mimic what we're doing already. A robot probably really should add additional value. And this is what we try to consider now with the LoKomat as well, and I want to show you a few examples what we are doing here. So in terms of active, meaningful treatment, again, if a robot is just moving a patient, that's probably not good enough. So we need more control from a patient. Again, self-initiation is critical. And with this new path cooperative control strategies, we certainly have now much better control strategy that allow a patient to have more control and initiate movement, and as well come up with a more individual gait pattern at the end. And obviously the feedback here, excuse me, a very simple feedback, but the more active a patient is, the more smiling face we have, the less active, obviously, the sadder the face at the end. Another example here, how this looks like. Oops, that was too early. How to understand, I don't want to go into technical details at all, but this is what we're doing. We kind of create a path here, and the patient should stay within this path. As long as we are within the path, it's fine. As soon as we are leaving this path, the robot will support and kick in and bring the patient back on track. And again, we see here the self-initiation of movement now kind of controlled by the patient. Now, in terms of meaningful and again active participation, what we realized is that we always thought, well, the LoKomat is just a tool, and it really depends how a therapist is using a LoKomat. Again, I fully agree there are patients out there that are almost sleeping in a LoKomat, and this is certainly not what we want to have. So we thought, well, the therapists, they will then encourage patients, and they will tell them, okay, bring your knee up, try to make a longer step, and it really didn't happen. So we thought, well, we probably have to, again, introduce something, robotics, that should be an additional value that probably creates more feedback, and in terms of that, motivates a patient more and engages a patient more during a treatment session. So this was a EU project. It's a huge name here, multimodal immersive motion rehab with interactive cognitive systems, and it looks even more complicated here. What the main question was, what kind of feedback do we have to provide to a patient to make this patient as engaged as possible, as actively participating as possible? And what you see here is a LoKomat in front of the LoKomat, a huge screen where we use some virtual reality component. We kind of reduce this screen and are now using a smaller one. And I want to show you this example of a version that we use now for CP patients or with the pediatric LoKomat. This is kind of a comic figure, and the patient now can kind of move this figure. We can turn right and left, and the more active we are, the more interesting this environment gets. So probably similar to the bar that you have, right? If you are successful, you get a nice bar. If you're a lower level, you probably have not such a nice bar. The same thing we want to do here, with the result that when we provide an environment that is not as exciting, we see here EMG pattern and we see heart rate, not really a lot of activity. When we provide an environment where patients can actively influence that, can become more an integral part of this environment, can change the environment, can see that probably something really changes and get the real feedback, then we have much more activity levels here on EMG levels, and we have higher heart rates as well. So this is certainly an important tool for us to make sure that patients are as active as possible, and with this activity obviously benefit more from the robotic support as well. These are some examples in terms of these virtual reality components as well. So in Avatar, we provide acoustic feedback, visual feedback, and can change certain environments. In this case, they need to catch objects. Stroke patients, probably we want to focus on a more symmetric gait pattern, so we try to let them walk as straight as possible, so the kind of patients who tend to push to one side, that we keep them in line and give them feedback with the treatment goal to be really as symmetric as possible. Just to close the gap here on virtual reality or on this augmented performance feedback, an example with children where we used kind of a soccer game. This looked like that. So this is kind of the the team they play against, and this is the patient, and they have to, again, become as active as possible to probably be able to kick the ball and score a goal at the end. So again, the main goal is really to provide feedback that encourages a patient to be as active as possible. And this was just reported there, so obviously it's fun doing training, it's probably helpful, and at the end I would like to rather use this VR component than just walking in a LoKomat without any feedback. And now it gets a little bit boring. Now we go into research, because one task was as well, you have to talk about what is out there in terms of evidence-based data. And it gets boring because there's quite a bit out there. So I'm not going to review all these papers, but it's pretty impressive. There are now more than 120 LoKomat publications out there, about 70 focusing on clinical, more efficacy-based topics, and quite a bit of research is still going on. When we look how these papers got together, at the beginning, obviously, it was more kind of a focus on, well, what is the technical components describing this device? It then did go into more feasibility, well, are patients accepting that? Are therapists accepting that? And then it goes obviously into efficacy, more basic science. A lot of LoKomats are used for complete spinal cord patients to focus on H reflex or certain questions that would have been difficult to answer without having a LoKomat and moving these patients. Obviously, as well, assessment capabilities, and now more the question as well, how do we have to use these tools in a clinical setting to benefit the most from them? I skipped this one. This is really more about basic research. Again, where are the main focus areas and kind of the publications that are available. In terms of CP, just a short summary here. All the studies here, there are new ones as well, but I didn't list them. It's really mainly focusing, obviously, on gait in terms of gait endurance, gait speed, gait symmetry, and there is right now not a real strong RCT available. So most of these studies are still kind of uncontrolled, LoKomat, not really, well, probably LoKomat versus control group, but not really randomized. So there are certainly limited data on the children population and CP. A little bit different in spinal cord. There are a few papers out there focusing again, obviously, on gait improvement. Main findings again is in gait endurance, gait speed, and a nice study which I want to show you shortly. Skip this. Well, probably just as a, and I think that's important when we interpret kind of clinical data. It's always a question: what kind of patients do we select for our studies? And what this is one of the first ones, a multi-site trial between Switzerland, RIC, and Germany, and what that chronic spinal cord patients on the LoKomat, what we see here, each dot represents a patient, and we see here kind of the change in gait speed, initial gait speed, and here change in initial distance. So after LoKomat, they improved more than 200% in terms of gait speed, or here in terms of initial distance. But what we see as well, that the patients who've been very slowly walking at the beginning improved the most. And patients who couldn't cover a long distance at the beginning improved the most. So it certainly depends what kind of patients do benefit the most and what are probably the responders versus the non-responders. So I fully agree. The question is probably really as well to identify which or who is appropriate for a LoKomat, for instance. When do we have to apply this modality, for how long? And so a lot of clinical questions that will probably help us later on to understand how successful this kind of technology can be used eventually. This is a study for UT Southwestern in Dallas where they did fMRI pre-post LoKomat and could see that obviously here this is before LoKomat, after LoKomat, that there are supraspinal changes in spinal cord patients after about 12 sessions of LoKomat intervention. In stroke, and again, I don't want to go too much into details, main finding probably that stroke patients benefit in terms of gait symmetry. And I want to show you this one shortly. Well, before I go into gait symmetry, one notion is always out there is, well, how active really is a LoKomat? Or how active does a patient has to be in a LoKomat? And what they've done here, this is an RCT, included about 20 patients. They reviewed what happens on body composition levels. And what they found after LoKomat, control group is LoKomat, is actually conventional overground training. Treatment group is LoKomat. On body weight, not a huge change. The LoKomat group reduced a little bit, control gained a little bit. But interesting is now on body cell mass, the LoKomat group increased body cell mass, kind of translates to muscle mass, versus control group lost. And on fat mass, control group increased versus LoKomat group decreased. So a clear indication that on a body compositional level, the LoKomat can have positive effects. And when we look at gait symmetry, then this is probably a typical stroke patient we know. Single support phase, so the hemiplegic leg, the impaired leg, patients tend not to be able to stand on this leg for a long period of time. So certainly a reduced stance phase. And what this study could show, done in Germany, that these are two groups here. So we have the paretic leg is here. This is the LoKomat group, control group. This is the healthy leg of the LoKomat group patients and the control group patients. So when we look at stance phase, then obviously on the impaired side, both groups had a reduced stance phase, which is this black bar, versus both groups on the healthy side had kind of a normal stance phase duration. Now after LoKomat intervention, the LoKomat group improved stance phase almost to kind of a normal 60% stance phase, versus the control group didn't improve. So again, an indication, if we select the right patients who are probably non-ambulatory but have a potential to improve, that these patients will end up with a more symmetric gait pattern after LoKomat intervention. And to summarize this shortly, I think this illustrates fairly nicely how we have to interpret this data. So we have non-ambulatory versus ambulatory patients, so kind of an improvement in functionality indicated as well here. So here low level, and then obviously motor function improves. And at the same time, we probably need more support in an initial phase or in patients with less functionality, and want to reduce the support over time. And this indicates as well the studies that are out there. If we review all publications done in this kind of group of patients, we see positive results or significant improvements from LoKomat versus conventional. And when we review the publications here, where we have patients on the LoKomat, which probably have been ambulatory already, then the LoKomat probably provided too much support, and the result was not significantly better in the LoKomat group versus conventional gait training group. So I think main message here, it's really important to understand what kind of patients are used or are selected, and when are they selected in the rehab phase. I don't want to skip this one here. So to end up my talk now, what's next? I'm not going to go, well, now after LoKomat we have exoskeletons. I'm sure exoskeletons will be there, but I fully agree it's probably more on an assistive level than on a rehab level as of now. I think from our LoKomat perspective, very important is now to understand, well, how do we integrate all these technologies in a clinical setting? And again, the question about who is probably responding, who is not responding, what are the right outcome measures to select. And I think an interesting modality is now done at RIC, where they created a so-called ability lab. So the main concept is to understand how do we really have to incorporate now all these different technologies to have the best treatment outcomes. And this was kind of an idea how they created, and this is now how it looks like. So they have a huge gym where they have various technologies and want to now understand, again, how this needs to be integrated and incorporated to have best treatment outcomes at the end. We try at the same time, and this is going to be my last slide, not second last slide, to understand as well by measuring and getting much more data to understand how do we, again, apply these technologies in the future. And collaboration of an international group here, although quite US-based, where we want to find standardizations of LoKomat treatment, but as well upper extremity treatments, with the main goal to learn much more and having much more centers in the future that deliver data, which will help us then to understand how we really have to use this technology the best way. And that's the last one. I want to thank you. And an outlook, the ones that are interested in pediatric rehab, there will be an important symposium in this October at RSE, together with the South American group, Central American group, where we again want to not only focus on the US market, but want to incorporate as well findings from other parts of the world to benefit as much as possible. So thank you very much.